Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Today, our guest is Dr. Lihi Eder, a clinician scientist at Women's College Research Institute and associate professor of medicine, University of Toronto in Canada. Dr. Eder has a broad background in rheumatology with specific training and expertise in psoriatic arthritis, musculoskeletal ultrasound, and cardiovascular diseases in rheumatic patients. She's also the co-director of the Cardio-Rheumatology Clinic at Women's Hospital, which is Canada's first clinic specializing in the early screening and treatment of heart disease in individuals with rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Through her work, she aims to improve the management of rheumatic diseases and also studies the barriers to equitable care in rheumatology, including the role of sex and gender as determinants of disease outcomes. Dr. Eder, thank you for joining us. I'm really excited to talk to you a little bit about the intersection of our hearts and our rheumatic diseases today.
Thank you, Jill. It's a pleasure to be here.
So I have to ask before we even get started, I heard recently a quote not related to rheumatology, but it resonates with me here, which is the first one through the door opens it for the rest of us. So I'm very curious what inspired the Cardio-Rheumatology Clinic.
Thank you. I should say that starting as a fellow, I was doing my advanced training in Toronto, and I found that it's really fascinating, this intersection of the heart and vessels and inflammation. And I started studying it, and when you read my bio, you can see that I'm interested in multiple things, but imaging is also one of these. And I started doing ultrasound of the carotid arteries and looking at, the progression of this disease in people mostly with psoriatic arthritis. And then when I became faculty, it turns out that my boss there, our physician-in-chief, who is a cardiologist, is also interested in cardiorheumatology. She was mostly managing patients with lupus and the heart complications, but we started to think together how we can improve care of patients and also advance research at the same time. So we had really good connection at the personal level, but also a professional level. And we created this combined program that was, as you mentioned, the first one in Canada and one of the first one in the world, in fact. So,
yeah.
And I'm really glad to see that this topic is picking up, because within the cardiology area, there are now more and more cardio-rheumatology programs, and the cardiologists are starting to realize that this is an important topic. And there is now one in Harvard now, and in NYU. So I think it's really nice to see that there is more. I guess people are starting to acknowledge this, that it is an important topic to study and to manage patients better.
Yeah, and the cross collaboration, I'm sure, is so important across the different specialties. Kind of finding the spots where the boundaries intersect, I think is, to me, that's how we all drive change, right? So,
yes.
So we're grateful for your work. So, can you tell us a little bit about some of the risks related to cardiovascular with patients who have rheumatological diseases? Or spondylitis in particular, I guess.
So I think the common theme across different rheumatic conditions is inflammation. So we know that whether people have rheumatoid arthritis, whether they have spondyloarthritis, whether they have psoriatic arthritis, or even osteoarthritis, which is not considered to be inflammatory, but there is a component of chronic inflammation. Inflammation is not good for the joints, but it also not good for the heart and for the blood vessels. We also know now there is advanced in understanding that atherosclerosis, which is the process that includes buildup of plaques that contain cholesterol and other things within the arteries, which is the process that eventually leads to heart attacks and stroke and angina. This process is driven by inflammation. It's like a low-grade inflammation in the blood vessels. So cholesterol is important, but it's not just the cholesterol component. So having a condition that involves chronic inflammation has an influence not just on the joints, but also on the blood vessel, on the development and progression and rupture of plaques that eventually lead to these conditions. So I think we can talk more about mechanisms, but I think inflammation is the common theme that is relevant to spondyloarthritis as well as to other conditions that leads to the increased risk of developing these conditions, heart attack, stroke, angina, and so on.
So one question I have, so you focus a lot on ultrasound, and you were saying a lot of the arteries and blood vessels. Is some of the correlation between the ultrasound work around cardiac, I'll just put it in the I don't know if that's the right word, but when you're looking at arteries and blood vessels, is there a correlation to what is seen in ultrasound around like inflammation of the joints and enthesitis? Is that where the intersection is?
Yeah, so it's a very good question, and you don't necessarily. We've done some work that looked at carotid, so the arteries, which are the arteries that bring blood from the heart to the brain, and we can see and quantify how much plaques there are in these arteries, and we've shown that in people with psoriatic arthritis, there is a correlation between how much inflammation there is in their joints and what is the levels of inflammatory markers in the blood, which is another way to measure inflammation, and the extent of plaques in their arteries. There were many other studies done, mostly in rheumatoid, I should admit, but there were also studies in psoriatic arthritis, as well as fewer in ankylosing spondylitis, that showed that having more intense inflammation, uncontrolled inflammation, whether you measure it by the number of tender and swollen joints, whether you measure it by levels of CRP, which is a measure of inflammation, these people are at higher risk of future development of heart attack, stroke, angina. And so this is another way to kind of show that controlling inflammation is very important when we consider ways to reduce the future cardiovascular risk.
So I'm going to throw a curveball at you because I just had a thought that turns into a question, because cardiovascular health is so important, and it is a massive killer of people, and we know that things like ankylosing spondylitis or spondyloarthritis are like a 7 to 10 year diagnosis cycle, and inflammation is at the core of all of this.
Yep.
Why, when we go to our general practitioner, aren't we asking questions about inflammation? Right? Because I know that there's a lot of subjective sort of self-reported or self-submitted data around it, and there's blood work. And I think a lot of people who have diseases like SPA are, it doesn't always show up in the blood, but the inflammation is there when we look at like joints. So why aren't we talking about inflammation at the GP level, the general practitioner level?
So I'm glad that you asked this, because it goes back to a little bit to the management of how can we prevent future cardiovascular events in people that already have a diagnosis of spondyloarthritis, and who should be responsible. Is it the responsibility of the rheumatologist? Is this the responsibility of the family physician? Is it because I think among rheumatologists, it's sort of well known that pretty much all of the cardiovascular, all of the rheumatic conditions, systemic rheumatic conditions, are associated with increased risk, and that we should pay attention. We should check the blood pressure, we should check cholesterol. But then it brings up the question, who should manage? Like, let's say we found high blood pressure, we found cholesterol. Is it the responsibility of the rheumatologist to take care of this, or should this be the responsibility of the family physician? Cardio-rheumatology programs like the program that we have in Toronto are not common. So it's hard,
Right.
like it's eventually the bigger community of patients or people who live with spondyloarthritis don't have access to such programs. I believe that it should be a combined or collaborative model. And I would also include the patients here, because I think many family physicians are unaware of that increased risk.
Yeah.
I believe that it is responsibility of the rheumatologist to screen for these risk factors. But many rheumatologists don't feel comfortable and don't have the updated knowledge of management and don't have the time practically to manage all of the health issues.
Yeah.
But it's their responsibility to educate both people who live with spondyloarthritis and the family physicians, and communicate this in notes or in other
Yeah.
ways to make sure that these are being taken care of. And here I also include people who live with spondyloarthritis, because there is also lack of knowledge there, and many people are unaware of this connection. And I
Right.
think advocating for yourself is also very important.
Oh,
So,
I agree. I have like an infographic in my head now that's like, here's you at the center, and here are all the things we need to manage to get better outcomes. Okay. So once someone is diagnosed with spondyloarthritis or is starting to become concerned, like what role does monitoring the cardiovascular piece play in reducing outcomes? Is what importance is monitoring? We just touched on this a little bit, but how do you monitor this? What are we looking for?
so I think what I try to do, and I believe that works better from my experience, when someone is being diagnosed, receives a diagnosis of spondyloarthritis, psoriatic arthritis, many times it's overwhelming. There are lots of many topics to discuss and to deal with, especially if the disease is very active, and now there needs to be considerations of what medications to start and to get the disease under control. In my opinion, that's not the best time to start talking about cardiovascular risk, because there are more urgent things to consider. There are also issues around measurements of lipids that can change with some medications, or with more intense inflammation. These levels tend to fluctuate and may change when someone reaches a remission or gets to a stable level. So I try to discuss these topics with my patients when the disease is sort of uncontrolled, and when someone is kind of more, I would say, available to listen and to consider this topic. And then I think is the right time to start managing and screening and discussing cardiovascular risk. As I mentioned, the measurements of lipids can change, so it's better to measure it when the disease is stable, not when we make changes in medications. Of course, there are caveats, and sometimes we do need to do this risk stratification, which is basically assessment of the actual risk, because some medications are not allowed to be prescribed in people that are at a very high risk, or people that already have a history of heart attacks.
Oh,
Or
like a biologic or a medication to treat the spondyloarthritis.
exactly, some
Okay.
medications may actually increase the risk. I don't know if you want to touch on that, but there are
Well,
some new data, so
yeah, a
this is
little.
something to be.
Yeah, we do. I think we do want to touch on that because how do those medications used to treat the disease affect heart health, and how do we take the right precautions?
So in spondyloarthritis, and there is similarities between, I consider it within the spondyloarthritis, psoriatic arthritis, and axial SpA. Most of these medications, so there is a little bit of a broader range in psoriatic arthritis than in axial SpA in terms of the classes of biologics that are approved. But generally speaking, most of the injectable or all of the injectable biologics have not been shown to increase the risk of cardiovascular events. In fact, especially with the TNF inhibitors, medications like adalimumab or etanercept, these have been around for a long time, and there's been studies that show that they may even reduce the risk, so they may be even protective. The issue is important with a newer class of advanced therapies that is called JAK inhibitors.
Sure.
These are oral medications, so they're given as tablets. And there has been some safety concerns regarding an increased risk of developing cardiovascular events and DVT, deep vein thrombosis, or pulmonary emboli with these medications, and therefore this class received the black box warning from the FDA. So when we consider this, we have to discuss these potential risks with patients. Now, I should say at this point, it's very important for the rheumatologist to make this risk assessment, because the risk is very, very, very low in young people, in people who don't smoke, in people who don't have any of the cardiovascular risk factors. But it's much higher in older people, especially above the age of 65, and people that are current smokers and people who already had heart attacks. So in this situation, it becomes a discussion of the risk versus the benefit, because these medications are also very, very, very effective to control inflammation. In some people who have failed multiple biologic medications, this may be the only option for them. And then it's, weighing this risk versus benefit. And many people are willing, to, it's ultimately, I think it's a mutual decision between the rheumatologist and the patient, but the patient needs to get the accurate information about safety issues.
Okay. And this, I'm going to take a little turn because we did have a question from a listener, and I think this is the appropriate spot for it, which is, does having SpA increase the risk of blood clots and deep vein thrombosis? What do we know about that? And you mentioned a tie to some of the JAK inhibitors, and I don't know if that was the context of the question, but it sounds like there is a concern, but I know that JAK inhibitors are also new, and sometimes we don't know until we have a little more data. So I'm going to seek the expert advice here.
So you're right. I suspect that this question came in relation to maybe consideration of JAK inhibitors. So deep vein thrombosis are, unlike cardiovascular, so like heart attacks or strokes, which are affecting the arteries, which are the vessels that bring blood to the organ, and therefore the relation to atherosclerosis and plaques and all of the things that I mentioned before. Deep vein thrombosis are affecting the veins. So the mechanisms are a little bit different, but the relationship with JAKs in terms of safety issues, they consider both arterial as well as venous problems or thrombosis. The black box warning that I mentioned is relevant for this issue as well. There's been less studies in spondyloarthritis and psoriatic arthritis regarding DVT and pulmonary emboli, but there seems to be a higher risk compared to the general population. Okay, so it's probably also related to the inflammation that I mentioned before. Inflammation is not good for the blood vessels, whether this is arteries or veins. And as well, they are also associated with some of the other issues or comorbidities that tend to be associated with spondyloarthritis. So, for example, we've done a study in psoriatic arthritis, and we found that obesity and diabetes are associated with an increased risk of developing DVT and pulmonary emboli. So some of these issues that tend to kind of be associated with these conditions also increase the risk of DVT and PE.
Okay.
So it's also, again, it's what we call risk stratification. So discussing this risk and finding whether someone has these risk factors of developing deep vein thrombosis. So, for example, if someone already had it before, then that's a high risk of recurrence. I would not prescribe a JAK inhibitor to someone who has a history of DVT.
Right.
So
Okay.
these kinds of things need to be assessed by the rheumatologist, and they then considered whether this person is at high risk, and that may not be the right drug for them.
Yeah, and I know it can be scary when you start a new medication, and whether it's, in this case, like a DVT risk, and somebody says, well, you have a 50% increased risk of getting DVT, and maybe the general population is 1 in 1,000. So you go from 1 to 1.5 in 1,000, and then you stratify the risk based on what's, I guess, I don't know if the right word here is like what's statistically relevant, but you would look at a bump. So I think that it's really, it becomes more than just the warning is there. Your advice is make sure you talk to your rheumatologist and really understand how they're looking at the risk for you specifically.
Yeah, and I think, Jill, this is a very important comment that you made, and thank you, because the absolute risk is very different than the relative risk. 50% sounds very scary, but going from 1 in 1,000 to 2 in 1,000 is not a lot. It's still a very low risk. So translating this within an individual scenario is very important.
Yeah, good. Okay, so let's pivot just a little bit. So we talk a lot on this podcast about what we eat and how we manage our stress. How does that play into better outcomes around heart health for people in general, I guess, and with also rheumatic diseases?
So I'll touch on stress first, because I think this is really important. It's important for many, many, many things, not just spondyloarthritis. I think there are many ways of addressing stress and managing it. And it's something that I think everyone needs to find the ways that work for them best. But there's been studies that looked at stress and also depression as comorbidities, and we know that at least in the general population there is a strong link between mental health and future cardiovascular risk. And that is a topic that we actually study in our clinic, because especially within the psoriatic arthritis population, there is a very strong link between overweight and the risk of developing psoriasis and psoriatic arthritis. And this brings the question, and it's a question that's coming up many times in almost every clinic: what should I eat and what shouldn't I eat in order to make my arthritis better? We are currently doing a study on diet. We are randomizing patients with psoriatic arthritis to different types of diet, and we hope that we'll have some new data in the hopefully next year. But I can say that I don't think there is one component in the diet. You know, some people tell me about tomatoes or other components. I think it's a whole thing of diet is many, many components. And generally speaking, we know that Mediterranean type of diet that is rich in fruits and vegetables and reduced in red meat and more fish and unprocessed food. So it's more principles rather than specific components. Is a diet that has been shown in multiple studies to improve cardiac health and may also be beneficial to inflammation, to reduce inflammation in general.
Okay. Good root cause. Um, so we did talk a little bit about how people communicate with their healthcare providers about their heart health. So I just want to circle back on this because I think it's important to look at our responsibility as the patient, but also is it I find it's recommended, at least it works for me. I'm very direct with my doctors about like, can you help me understand this or can you help me manage this? Or I've chosen to now, when you were talking about blood work, I only get blood work done with my rheumatologist. And and another doctor tells me to get blood work, I say, well, get it when I get my 6-month blood work done. And then it's all in one central location. So in terms of communication, any strategies you recommend to streamline the confusion when you have multiple doctors and specialists involved?
I believe in family medicine, to be honest. I think they have to be the coordinator of care, and because things become so complex and many of us rheumatologists are getting so specialized in one area, I think it's very important that the family physician is aware of what's going on and
Sure.
take responsibility on topics like managing blood pressure and managing cholesterol, lipids, because rheumatologists, as they go further away from their internal medicine training, many of us are not updated in new medications. And there's been lots of advances in the field of diabetes, for example, has had huge advances. And we are not, most of us rheumatologists are not comfortable in prescribing this. So if a family physician is assuming that the rheumatologist is managing everything, I think that's the wrong message. I think family physician can and know better than rheumatologists how to manage these things. And I think it's important that they are aware of what is going on and manage these particular conditions. I think the rheumatologists are the ones that take responsibility on risk stratification and make sure that they consider all of these things. As I mentioned, it's important for selecting with biologic therapies. It's important to inform the patients of potential risks. There are other aspects, but ultimately, I think it should be ideally collaborative approach rather than someone taking responsibility.
Yeah, and I'm lucky because my 2 doctors they collaborate well together. But it also comes into, right, because if we're talking about rheumatology related to heart health, that could also be when I think about the family physician, we also have, right, you have to go get your mammogram and your colonoscopy and all of your other recommended screenings and tests at regular intervals. And I think about this a lot, in fact, to the point where we added a policy at work this year that if you get all of your recommended screenings annually that your doctor recommends, you get a bonus week of vacation.
That's great.
Because to me, it's so important for people to be thinking about these things because it's a long game. And it's important to look at ourselves as a system.
I absolutely agree. I think our systems, I can say in Canada that there are many people with no family physicians. There is not enough family physicians. And that's really our country is failing people because preventative medicine is so important. So
Yeah.
yes, I absolutely agree with you that, and that's I think one reason maybe we're having this conversation is that people sometimes we're not in an ideal situation where the system is taking care of us, and it's our responsibility to advocate for ourselves and make our healthcare provider aware that, or remind them that this is important. We expect this to happen.
Yeah. We had an episode air the other day, and I think what we landed on, this was related to discussing workplace illness in the workplace. And it was, we are responsible for asking for what we need, I think is what Dr. Jaffe said, which is really interesting. So let's talk a little bit about complementary therapies. Do you recommend anything like acupuncture, massage that helps in improving heart health, reducing the inflammation?
I think specifically these are meant to reduce symptoms rather than improve inflammation. I'm not aware of studies that show that they actually reduce inflammation. That goes to supplements as well. I'm not aware of supplements that have been shown to reduce inflammation.
Okay.
I think generally speaking, whatever, and we haven't spoken about physical activity and exercise, but whatever allows people to be more active and move or get up and move is critical, because exercise is medicine, and it's been shown multiple times that people who engage in regular activity, even as little as walking 20 minutes 5 days a week, is enough to, or is better than doing nothing. So especially in people who live with arthritis, pain is a major thing, and it can, reduce activity. So if acupuncture or massage therapy reduces the stiffness and reduces the pain and allows people to move, it's important.
Yeah, because it can be tough, I know, for a lot of people. So do you recommend if somebody's not moving and doing a lot of physical activity that they just start small and keep increasing?
Yeah, that's my recommendation. So I talk about exercise again when people are getting into a stable stage. So initially, when the disease is very, very active, when the joints are inflamed, it's very hard to do exercise.
Yes.
And so at this point, I'm focusing on the medication and management of this. But then if people are left with some residual pain, then I discuss starting slow and in gradually increasing. I also discuss the fact that people can take some medications to reduce pain an hour before they plan on doing something, and that will allow them to complete the 20 minutes, half an hour walk or stretching, as a way to slowly increase this.
I like it. Is there any recommended standard of care just to, if you have spondyloarthritis or rheumatic disease, are there specific tests you'd want to be out there ensuring you're getting every year? And maybe this goes back to talking to your family physician and you're looking at managing.
Yeah, so I would say because of that general increased risk, it is recommended that even young people would have their blood pressure, cholesterol or lipids, cholesterol, and glucose sugar levels in the blood checked at least every several years. When people are getting older, in men, it's a bit earlier, above the age of 40. In women, it's when they become after menopause, so around the age of 50, then it's recommended every year. So seeing your family physician every year and getting these things checked. I should mention, though, that of course, if you have symptoms, so if you have chest pain, if you have shortness of breath, or if you have anything that is concerning of something that may be related to the heart, you need to check it anyways before that time period. Sometimes symptoms can be tricky because pain is something that can come from the muscles or the joints, and there might be arthritis in the chest joints, and that can be confusing. So I think it's better to be on the side where you are more cautious and go to see your family physician and discuss it, and they can decide whether they think this is due to a heart issue or this is due to the arthritis. And having this thing checked, especially in, I would say, women that tend to underestimate and kind of say, okay, take care of everyone else, but not themselves. So go and check if you have symptoms.
Okay, so I'm going to summarize maybe 4 bullet points that I think are how someone with SPA or a rheumatic disease can continue to maintain a healthy heart, right? So what I heard in the last 40 or so minutes is regular screenings and preventative, advocating for yourself and trying to coordinate with your docs, diet, leaning toward heart healthy, like a Mediterranean diet, and continuing to be active. Did I miss that? And taking your and mental. What did we go through? Anything else?
One last thing that I didn't mention is stop smoking if you do smoke. That this is really, really important. Smoking is bad for everything, including the spondyloarthritis and the heart. So that's yes. There are ways that there are now treatments that can help people stop smoking. So
yes,
that's again consulting with a family physician as well.
Yes, and in fact, on Wednesday we just interviewed Carol Southard, who is a smoking cessation specialist. So we just had that conversation, which is good. All right, so we're about at our time, and I just want to know, did we miss anything? And to just say thank you for the commitment and the work you did to forge ahead on the cardio room clinic.
Thank you, Anna. I enjoyed the conversation. I hope that people will find it helpful and informative. And yeah, thank you for having me.
Great. All right. Well, we will definitely, I'm sure we'll have more questions in the future for you. Thank you, Dr. Eder. SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit, educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.